If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you. All right, Emily Evans, welcome back to Health Further. Vic is out of town, so we're all on Zoom today. And it's October 15th as we're recording this. United Health Group did their public investor report today. And as always, we have you coming in at the end of one quarter, beginning of the next quarter to kind of give us just the theme that you are most tracking, right? And this time, I think we're going to dig into this storm that is all things Medicare. It's been the last week at, just so you know, Emily, last week at Nashville Healthcare Sessions, this was basically the theme, sort of the impending sense of doom around Medicare and the uncertainty around it. So I'm
glad they're catching up.
Oh yeah, no, I wanted to let you know that the industry is definitely getting the message about what's going on here. But you've got some good data points that we'll just all talk through, and I guess I'll go ahead and share the screen and get this started and turn it over to you.
Okay, great.
Let's start here with your overview of the consumer model.
Yeah, and let me preface this by saying United Health Group reported this morning. And one of the key takeaways was an increase in their benefit ratio, which means that people that they're paying more for their members to get treatment, and they cited some problems with Medicaid, and they cited higher utilization. But I actually think there's a lot more at play here, which actually would suggest not a problem for a few quarters, but actually a problem that's going to stretch, through the next decade or so. And I've been talking about this for about a year, so I'm glad to hear the industry's catching up, because it is definitely a change. So what we do is we have a model where we keep track as best we can as to who's insured by what. Well, how do they get their health insurance? And this model is based on recorded data through June. Medicaid is very much a laggard when it comes to recording data, so we forecast that, and that's what the pink bars are to the right. We have real recorded data for Medicare on a monthly basis, and this is through September. And we have to model the Affordable Care Act marketplace, and that's the dark purple. And we model that based on Treasury receipts and some other tools at our disposal. But as you can see, health insurance coverage in America is extremely robust. It is, that you add up all those bars through August, you're talking about 300 million people. There's about 320 million people in this country. Some of that chart's got duplication, because if you're insured through your employer and you're on Medicare, you would show up twice. But nonetheless, you have just an extraordinarily robust health insurance coverage, which of course is the goal and was the goal of our federal policy and a lot of state policies since around the 1990s. So goal achieved, right?
Yep.
Okay, so if we look at the next one now, there's a few trends I want to talk to you both about that I think tell us that we are at an inflection point. And in healthcare, of course, inflection points could last for years, right? But the better the sooner you know about it, the better you are. Although, as I've learned, not too soon. You don't want to figure it out too soon. But in one of the trends that became kind of clear in 2021, but I was waiting to see what 2022 data or what 2023 data would tell me. And this is a annual survey Kaiser Family Foundation does. We're going to see 2024 data this month, which will help us know whether our trend that we're tracking here is real, or is it something that is. Yeah, is it a blip? And so if you look at family coverage, and you see to the left of 2019, you can see family coverage and single coverage, the percent that the employee is asked to pay, kind of right there in line, right? Not perfect, but you can see the relationship. Beginning around 2019, but certainly by 2021 and 2023, with this dip in 2022, which I am told is a result of actuarial calculations due to utilization trends. This is a theme you guys are going to hear more about in a minute. The employer-sponsored plan is trying to shift as much of its employees' family to another insurer. Now, that could be a spouse who is working and is employed and will take that because that particular employer plan is more robust. Like if you had a spouse working for the government, for example, or it's because they're just haven't caught up and you're doing a little arbitrage play. We don't know, but you're definitely seeing a shift towards okay, we're gonna insure the employee. We're gonna provide great insurance for the employee, but your family is a little more on their own. We're gonna make less of a contribution for your family. This has the effect of kind of breaking a little bit of that social contract on which the whole premise of employer-sponsored health insurance is made, which is you're an employee, your family is with us, we're all kind of in this social contract together, and this is eroding that somewhat. The Affordable Care Act family glitch rule is likely contributing to that, which allows people, if they can't be insured by the employer, there isn't a spouse who can pick up the insurance. You can go to the Affordable Care Act plans and use those, which is something we could not do before 2021 when the Biden administration reversed the Obama administration's take on that. So next slide.
And probably reversed
the courts are going to reverse it. I mean, you had the Justice Department. I mean, you've got this file, 2 inches thick, saying you cannot change this, and then Biden went and changed it, and the courts will tear that down. So I'm mentioning it because it's having this effect, but ultimately, I think it'll be, those people will be stranded. And they will either just have to, buy individual insurance,
Wow.
Or employers are going to have to adjust. We'll see how that plays out.
And
that's not a good setup.
That's going to be something important to track, because that will be quite expensive for households if in fact you have to sort of go person by person in a household.
Yeah, that's right. This is something else that we've been keeping track of because of the family coverage being punished, if you will, by employers asking employees to pay more share of that family coverage. What you've seen is a decline in 21, and then in 22, and again in 23, of the ratio of employed to insured. The District of Columbia being a very notable exception. The District of Columbia, of course, employs a lot of federal workers. Those federal workers are typically 2-income families, and the federal health insurance program is extremely robust. So you just don't see that kind of decline. But if you go and you look at, say New Hampshire or New Jersey, you've seen a fairly pronounced decline in the number of people insured under a particular employer plan. And again, it's the shift: get the family off of the employer's insurance, take care of the employee, and that, I think that's going to continue to be a challenge for the affordability of health insurance, simply because if you're taking if the employee has to pay a bigger share of the insurance, they're more likely to go, nah, I can't do it, and roll the dice, which is which is unfortunate, but that's the result of high costs. So
I'm just eyeballing this chart, but it does look like quite a drop in California. Is that right?
yeah, that would make sense.
Yeah,
California is, such a heavily regulated state that insurance is high and the provider costs are
right,
so high.
right. Yeah. And also looks like a not insignificant drop in New York as well. So
Not insignificant. Interestingly, look at Utah. Utah's pretty tight. So Utah has one of the highest ratios of employed individual to insured individual because the influence of the Mormon faith and the size of the families and so they're sticking with their social contract in
a lot of ways in Utah they they're very committed to their social contract there.
Yeah. Okay. So then, that's the kind of the worries in the employer sponsored insurance commercial, and that's important because that's where the margin is for providers. I will also say that's where the sclerosis is, right? Because but employers just don't seem to want to, innovate at all. But that's definitely where a lot of the margin is because it's commercial insurance.
Can you just say a little bit more about the challenge of the margin and commercial insurance and how that ties to the employers pushing families just by virtue of lowering their contribution to the family plan?
Yeah, and it depends on where the family goes. All right.
Yeah.
But
right.
But if you typically an employee, an individual employed by, say, a self-insured commercial plan, and that could be anybody employed at a entity that says have over 75 people. That would be a common scenario. In that case, what you're doing is, in that case, the providers, when they're paid by that employer sponsored insurance, they're usually paid 2 times the Medicaid rate, sometimes 3 times the Medicaid rate. And it is where a lot of the margin happens in the provider space, particularly in the amongst the hospitals, where they will don't ask me why, but employers will pay premium prices at local hospitals for their insured, and that's where a lot of the bread and butter is for the providers in a particular community.
Yep.
And so,
and Emily, I think that the reason why is competitive labor markets. When they are competitive, it then swings to that they want certain health systems or providers in network, and so the ASO book ends up being more competitive than the government book.
But I would think that the way in which consolidation has happened, that they would have like the city of Nashville, that's a huge plan. Yeah, you would think that they would have done a better job of negotiating those rates, but because 200% of the Medicare rate of the Medicare, it's a little egregious, right? How about 125% or 130?
Yeah, I just don't think that the network, the payers managing the ASO book on behalf of the employers, they're not incented like that. They want to make sure they get the Vanderbilt pediatric hospital in network, and then their customer, Nashville city government, is not that price sensitive. So
right. Yeah, and that's and the question is, how long is that going to endure, right? Yep. But that's in this industry. The setup is commercial, yay, awesome.
Right.
Medicare, okay. Medicaid, until certain changes recently were made, which now allows Medicaid to compete more with commercial. But that's how the industry is, always looked at that mix of business. It's becoming this the case.
One final thing I want to say, and then you've got some other talking points I want to make sure we get to, but there is an interesting circular dynamic there where this is exactly where the certificate of need and price transparency and all of those things that that limit the impact for competitiveness, specifically at the health system level in communities, plays to the disadvantage of employers. And I feel like because employers are not in the business of healthcare, they sort of outsource all this to brokers for the most part, right? I think that's the other thing. Employers are just not really actively playing this game. They're doing it out of necessity, not because this is their fundamental game. I think as the cost continues to go up, we might see that change, but they're going to lose, in those negotiations because they're just not. They don't have a lot of optionality.
Right.
They don't have price transparency, and at the end of the day, as you said, the employer is in the position where they are looked at because of the implied social contract as on the hook for this anyway, and providing what the employee wants here, right? So so the only way out is not going to be negotiating better rates. It's going to be changing what they're willing to do for the employee.
I think that's right, and I think I mean, how many CEOs do you know who can't wait to talk about benefit expense, right?
Yeah.
They just that's right down there in the SG&A line. Please do not bother me about it, right? And they just like it never makes it to the C-suite. It stays in HR, and they proceed to do whatever they need to do, not to attract any attention from the C-suite. So let me move on to the crisis in Medicare, which actually is, if I want to rank order the problems here, Medicare is presenting us with some very significant issues, and then after that, somewhat Medicaid. But then finally, I would say that the commercial and employer sponsored less so. But one of the things that happened in as part of the Inflation Reduction Act, which passed in the early 2022, is that it redesigned the prescription drug benefit in Medicare, and in effect moved the risk of higher drug prices and higher more expensive therapies, to the plan. It was originally with the government. So the government would pick up 80% in the catastrophic phase. So at that time, a $5,000 deductible. They would pick that, the government would pick up, that 80%, and the plan would have to pay, I think, 15%, and the manufacturer 5%, which of course results in what? The plan saying, oh, let's buy the most expensive drugs we possibly can, because we'll get that patient up into the catastrophic phase, and it'll be the government's problem, not ours. Well, that's flipped now, and the government is paying a smaller share. The plans are paying a larger share, and the plans have to adjust for that. And one of the things that's been ongoing for a while is trying to get people out of the prescription drug plan, standalone plan, typically paired with traditional Medicare, get them out of that and into a Medicare Advantage plan paired with prescription drug benefit. And you could see this kind of steady decline through 17 and 18 as the prescription drug plans provided incentives to get people to switch to a Medicare Advantage and PDP plan. So that was this process. Now you see this vertical line in January of 2024 that makes it look like that's been reversed. Well, no, It hasn't. What happened was the federal employees health plan moved its Medicare eligible population onto the PDP standalone PDP plans, and that's why you see that effect. So the decline is going to be restored here as we move to the right, and what you're going to see is a continued decline. Now, CMS has said, okay, we're going to do this demonstration because what's happening is premiums are doubling in the prescription drug benefit, and we can't have that in an election year. So they've come up with this demonstration, which has got no basis under the Affordable Care Act demonstrations, but whatever, maybe it buys them time until, somebody stops them in early 2025, and maybe it works out. We'll see. But the fact of the matter is the benefit expense that is driving the doubling of those premiums is going to be It's not going anywhere. You
Mhm.
know, you can have a demonstration. It's still going to be there when the demonstration is over, or when the court says you can't do that. This is a important problem, because if you cannot get access to a standalone prescription drug plan, or you can't afford it because it went from $50 a month to $150 a month,
Right.
your options are Medicare Advantage
Advantage.
paired with PDP plan, or nothing. You know, who's gonna
direct
yeah,
cost plus drugs or whatever, right? I mean, like,
yeah, right. Who's going to, go with traditional Medicare without a prescription drug plan? The cost for a lot of people at that age level is the drug. So
Yep.
so this is the progressives in Congress hate this, because they do not want they don't want any incentives for Medicare Advantage. And that's what they've actually created, nonetheless. So this is a political problem. There's certainly a benefit ratio problem, but it is first and foremost a political problem.
So we have on one end, we have the pressures of the star ratings,
Yes.
right? That are making Medicare Advantage a far less attractive and maybe even palatable, model for managed care organizations.
Potentially, yes.
Right. And then potentially, yeah, because it's still up in the air how it's all sort of shaking out, but it's not looking good. That's for sure. Right. It's not looking good based on the last year of trends. And on the other side, we've got this pressure coming in from the premiums on the PDP that is actually hitting the households directly.
Yeah.
So they're going to be motivated and incentivized once they get those updates on what their premiums are, to move in the direction of Medicare Advantage. In some markets, there's going to be less options there, because we've had a rash of people exiting markets where they didn't have significant share from a Medicare Advantage perspective. So that's actually going to be a less competitive market with increased premiums, and probably increased premiums for the same or lower benefits. So on the whole, it's going to be the American citizen that's going to end up losing, right? I mean, the payers will adjust their models. They will adjust their models. They will adjust their incentives, or they will leave markets, right? They'll just decide to opt out entirely, where the margins don't work. Ultimately, the loser is going to be the 65 and over population in America.
Correct. And that is, it's a fairly politically active population, although I think one of the things we need to watch here in the coming year or so is exactly how much political power they still have.
Right, because that's shifting too. The millennials are definitely now. Go ahead, Vic. Sorry.
Well, I don't know if I agree that the shift to more people using Medicare Advantage is inherently negative. I think it does make sense the government is saying we want the payer, the underwriter, to be responsible for the prescription cost alongside the medical cost. And they're incentivizing this standalone prescription plan to not be as attractive, to get people to move towards Medicare Advantage. And then simultaneously, they're trying to push the star ratings to have more teeth, to have more impact.
Right.
I think that in the long run will benefit consumers, the over 65 crowd, but we have to have enough Medicare Advantage plans that there's coverage, that they exist in your market, wherever your market is. Is that the right framing?
And I think an important part of what you just said, has to do with the long run, because I think that this is a population. If you're, say, 75 and you're on a Medicare Advantage plan, or you had Medicare paired with a PDP plan, you've been getting some fairly robust coverage at a very attractive price relative to, say, if you were 64, for example. Okay. Your drug benefit, a lot of it was picked up by the government. And you were incentivized to get the best drugs on the market, because they were the most expensive, and that's what your insurer wanted. We'll get to what's going to drive some of the benefit design and the premiums of Medicare Advantage in a minute. But those two are going to be under pressure so that you're going as a Medicare beneficiary, from an expectation that this benefit that you've been paying into for a long time is going to be, more free than what your employer, what you're buying on the ACA exchanges or whatever. And that's not that thesis is going to be stretched. And that, I think, is where the problem will exist, is you're going to have some very unhappy people. And that's why CMS went and said, oh, we'll do this demo over the prescription drug plan, because they don't want to deal with the political consequences of that. But the real on the ground issue is that something that was free or almost free is no longer, it's not anywhere close to free, which we'll get to on the rest of the Medicare thing, if you want to flip the page there, Marcus. So Medicare population, we know this is coming, but we haven't been able to see it until really now, or maybe last quarter, when United Health Group started issuing some warnings, and that is that the population that is 65 to 69, those are people coming into Medicare. They're still playing tennis. They might even be running marathons. I don't know. But they're generally pretty healthy people. Okay. Even though they're, over 65. That population will still pay premiums into a Medicare Advantage plan, but not need a ton of services. Well, as you start to get older and the high cost bands are really 75 to 79 and 80 to 84, it's in that group where you see the most expensive utilization of healthcare services, more frequency and more expensive care. Mm-hmm. Well, that population, those two cohorts are growing. And they're growing simply because in 1947, 48, 49, you had this huge, birth, that's why they call them the boomers, right? You had a baby boom. And that group of people turned 65 in 2012 and on. And now they're hitting their highest utilization period. United Health Group says on their call, oh, well, it's higher utilization due to pent-up demand. I don't think it's that simple. I think what's actually going on here is, yes, pent-up demand, sure. I think that's a big part of it, and that's been a big part of our thesis. But I think the other part of it is the population covered in Medicare Advantage plans is getting older and demanding more services. They can't stay 65 forever, and I can't stay 39 forever. So that's, and you can see how this is changing. And 2020, it looks like there was an inflection point around 2017, but then another inflection point around 2020. And we didn't see it. We couldn't see it. Why couldn't we see it? Because of the public health emergency and all this money flowing into the system. And now, really beginning sort of the end of 23, and now clearly based on some things United Health Group is saying, and I don't think they're being entirely direct. I think they're telling you what they know, but I think they're probably missing this important demographic shift. And if you go to the next slide,
before we go to the next slide, I have a quick question. So boomers they started retiring in 2012. They're now something.
Well, they turned 65 in 2012. I don't know if they retired.
Okay. Right. They started being eligible for Medicare.
Right.
It looks to me like the over 85 two categories have not really changed significantly. Is that because the boomers haven't aged into that cohort yet?
They're still the biggest bolus of that population is 1947, 48, 49. And then it starts to normalize in the 50s. Even though you call the boomer population 45 to 64, you had much more normal fertility patterns, by the mid 50s. You still had pretty large families, that persisted into the 60s, but you definitely had had an unnaturally large group of children born in that immediate post-war period.
I guess my question is, like, is the higher age cohorts, are they going to start growing over the next few years, where this might even be further exacerbated? Or
it could be, but I think what you have natural mortality pressures there too, which will have some effect. And also, interestingly, if you look at utilization, medical utilization, it is it's not so high in on that 60 to 64 band. And then, but that 70 to 74 and 75 to 80 is where you see like a really chunk. For whatever reason, once you start hitting your late 80s and early 90s, there's less utilization. So even if that population grows, the effect on the premium pressure because of utilization may not actually develop in the same way and apply the same pressure as the population moves into these high utilization, high cost periods.
Well, I think I think there's two things there. First of all, I mean, my parents are in their mid 80s. That's the silent generation. So the boomers are not in that band at all yet. When you get there, the decisions get different, right? Because you've already beaten the life expectancy actually by a good clip. At this point, you've almost beaten it by 10 years. So the decisions become much more about quality of life, and you start having palliative care conversations, even if you're not on death's door, right? So you're not talking about a ton of utilization at that point. And Medicare really doesn't cover the palliative care offerings, right? So it just becomes more about, okay, you're going to live at home, or you're going to be in a nursing home, blah, blah, blah. But that's not really Medicare. Medicare is the inpatient, heavy, acute incident stuff. And even on the home health, it doesn't cover very much there as well. It doesn't cover those like final years that you're just sort of maintaining it. And so, it's good. I would expect the 70s to be where the utilization of inpatient stays and things like that, surgeries, stroke, heart attack, all would be the highest. That's what I would expect.
Yeah. And that's what we know from the HCUPS data is that's where you see that kind of utilization and that kind of cost, and then it starts to drop off once you get into certainly by the mid 80s. I mean, it gets to be kind of borderline unethical, once you start getting into the late 80s, because you're already playing with house money at that point.
That's right.
Okay, so this is the share, actual percentage share, and I think you can see the first of all, you can see the inflection more clearly around 2019, 2020, which we completely missed because of the public health emergency. And that's those blue boxes. That's the 75 to 79-year-old group. And then the lighter gray, that's the 70 to 74 group. And you can see that inflecting up. But at the same time, your 65 to 69, those are the people who pay premiums but don't actually use the services that much. You could see there was a bit of a decline there in that 15, 16, 17 range, and it's really pretty flat with kind of a bias to the downward trend. And what that means, of course, is that if you're a Medicare Advantage plan, for the federal government, but if you're a Medicare Advantage plan, you are going to have a lot continued utilization pressure simply because of demographics, and that utilization pressure is going to translate into premium pressure, which we are seeing now with the October release of plans, which is we're seeing higher out of pocket, we're seeing benefit reductions, we're seeing all the levers are getting pulled in order to balance these things out. And again, this population has enjoyed very low cost insurance for a very long time, and suddenly they're coming to face with these realities, which is a negative economically.
So, Emily, just one thing. I mean, at the highest levels, the people in the healthcare industry are very intelligent people, and they knew that this was coming, right? And so, I think you can see that there was going to need to be a shift somewhere in the overall payment model for how we were going to deal with Medicare. We've been talking about this for a while now. Now, the rate of change of the star ratings, obviously, the courts did not feel that rate of change was appropriate. But clearly, we're just at the beginning of a lot of regulatory changes that CMS is going to be forced to make with this trend line, right? I mean, as we have this very large generation moving into the very high utilization years, making up a larger percentage than they have. And I think we're about to talk about just cost, going up as well. It's going to put more pressure back on the payers and the providers, just because the government has to find ways to sort of cut this off. I mean, the punctuation here is the deficit is going to grow significantly. The percentage of GDP is going to grow significantly if there are not significant changes made to the Medicare model. I mean, that's it. So overall, the government, meaning the American population, the American people, will lose by way of the deficit growing, or the healthcare industry, by way of the payers and providers, will have to meaningfully adjust the way that they deliver care to this segment of the population, or the households are going to pay significantly more, and that, layered on top of it.
Don't forget, you have this unnaturally large piece of chunk of population. So once you get past 2027,
right?
Yeah, your rate of growth in that population is really going to get decline, and you have until 2040 roughly to make some changes, to do something different.
Right.
And at that point, you also have a political opportunity, because the political power of this group of people, will have shifted. So that's the way out. Now, I tend to think that there's going to have to be some deregulation of the system. I don't think there's any. I mean, we've probably been saying this forever. Everybody hates the working in healthcare. They hate the healthcare system, but it's getting to an untenable position when you start seeing erosion of Medicare enrollment, doctors enrolling in Medicare. You see erosion of that. The Heritage, one of the big practices here in town, they've got a lot of docs who don't take Medicare. There are, in heavily regulated states, getting a specialist on Medicare, very difficult. And that problem is going to have to be solved. And you can either throw money at it, which clearly hasn't worked, or you can start saying, all right, how do we allow people to go their own way? So let's go back to the Medicaid slide real quick, and then I just want to talk about the pressures, the sort of. United Health Group said today in their earnings call, we've got some timing issues with Medicaid. Medicaid redeterminations took place over about a year. Our data is saying it's pretty much done, and as a result of those redeterminations, you had healthy people who had jobs, whatever, leave the Medicaid enrollment. These are people who don't need a lot of healthcare services. And what's left behind are much sicker people. And so what United Health Group is saying, all right, we've got some timing issues where you have to kind of reset those capitation rates in order to accommodate these this new mix of sicker people. Now, there are a few states that are giving everybody a little bit of trouble, and these are identified for the American Community Health Insurance Plan Lobby Group, Michigan, Minnesota, New Mexico, Pennsylvania, and Virginia, where they aren't resetting their rates. They're not really catching up to this new population. And they can lean on models that the actuaries do, which include 20 and 21, where you didn't have a lot of utilization. And that is naturally depressing these capitation rates, which is something United Health Group is struggling through. This will wash through by 2020 or the end of 2027, but it'll continue to be, I think, a bit of a problem for the Medicaid, for the insurers in the Medicaid space, especially as state budgets get stressed a little bit especially ones that are dependent on sales tax because we're seeing less consumption, and a number of other factors. So I just mentioned that so people understand this is a little bit more of a simple timing problem, and I understand why United used those words.
Sure.
That's very fair. But it's a little bit more complex than that. So if we go to the last slide, we can talk about, we got obviously pressure on the benefit expense, which is putting pressure on the premium. So that's coming from the insurers, right?
Mm-hmm.
But at the same time, the providers are experiencing resurgence in their hourly wage costs. Yep. And you can see that uptick in the last few months there on the far right. And we've seen this translate into dramatically fewer job openings on a nominal basis. Mm-hmm. On a percentage of employed, it's still much higher than before the public health emergency. But you're seeing a fairly dramatic decline in job openings that began around January of 2024 and has accelerated here late in the year. And then on top of that, the employment in the sector has very much, on a month-over-month basis, still high numbers, running 3.5-4% added jobs each month, year over year. But still, but turning down a little bit. So we're seeing a little bit of a softness. Is that because insurers are going, boy, we can't keep paying for a lot of this stuff, or we can't keep paying the price? Is it because of the wages? The answer is it's probably both.
So I feel like the takeaway here is tremendous opportunity for innovation in Medicaid and
yes.
Holy cow.
Well, employer sponsored too. I mean, everyone is paying more than they would like to pay and having stress on the system. So, Emily, maybe as we sort of finish up, the election is going to happen before our next call. Mm-hmm. It's looking a toss up right now. I mean, various people will call it one way or the other. The only thing I've seen is the Senate seems likely to go Republican. Which
that's a high likelihood.
Yeah, and then depending on who you trust, you could say Kamala or Trump, or there's different views of it. But maybe just instead of making a prediction, give us a sense of if Democrats have the White House and we have a split Congress, or if Republicans have a White House with a split Congress, what should we be thinking about in healthcare?
I don't want this to sound partisan, but the problem with a Harris presidency, it's not partisan, it's just the facts of policymaking. The Harris presidency's healthcare policy is based on the Biden administration healthcare policy, which is based on the Obama administration healthcare policy, which is a derivative of the Clinton administration healthcare policy. So essentially, you've had very little evolution in healthcare policy from the perspective of the Democratic Party for 30 years. Okay. And particularly the last 15. Okay. And with Harris as the president, what you're going to do is continue to double down on those policies. That's what she said, which is preserving the Affordable Care Act. There are some bipartisan things like price transparency, I think that will continue to get done. Whether that affects anything, we will have to see. But the real problem, I think, is going to be that the policy, the regulatory system is protectionist for the sector, and
except for pharma.
Except for pharma. Thank you, Marcus. It's a good point. Pharma is a completely different story, and I don't think they really appreciate exactly what they're doing there. But that.
So, Emily, would you say that the big thrust from Clinton to Obama to Biden to Harris has been getting full insurance coverage?
Yeah.
And then a lot of federal support to the industry. Is that right? Or would you say
the way to think about it is, if you were a politician after the war, 1950, you're Eisenhower or Harry Truman, all of these countries were in Europe were establishing, universal health insurance, pay for everything. And that became the ideal. And that ideal has dominated the vision and the thinking of the policy for decades. Is that a good ideal? I don't think it fits the American model particularly well, but that's the ideal. And of course the problem with the ideal is there's no catch on the upward pressure in costs. And so
yeah, that and we're also approaching checking the box, we're finished with that idea. I mean, we have 320 million people covered.
Right. Yes. And I mean, we've mission accomplished. Congratulations, everyone. All right. Now you have to figure out how we're going to deal with the fact that the cost side is completely out of control.
Yeah.
And that is and
really the problem is that, I mean, there are several things that when I look on both sides of the aisle when it comes to the presidency, and for good reason, by the way, these are gnarly problems. I don't see any real solution because the real solution is so politically unattractive and maybe even palatable, right? Because somebody's got to lose big time to fix the cost issue, right? The free market will never commit suicide, right? Like it'll just leave a market, or it'll charge more premiums, or it will do what the free market always does.
Right.
So it's not them. It's the households on the large scale social contract, right? We might all have coverage, but the value of that coverage, I think, is likely to significantly deteriorate. And what's interesting is Gen X might be the generation to actually take it on the chin. Because by demography we don't have the numbers to beat the millennials on it. We're far enough out that I think what the boomers are going to do to the country from a financial perspective is going to be so devastating that they'll just say, that's it. You guys are on your own.
Well, I think that I agree with the free market does its own thing. I think Emily will know the facts. I think we spend something like $800 million a year in the administrative activity of reconciling all these payments, and which is 20%, 20% of the total cost. And that just seems like a lot of money to be spending on adjudication and moving things around.
Yeah, it's the system is reaching an absurdity, right? With the way in which you've got computers at the big insurance companies talking to the big healthcare providers, each one trying to figure out how it can get the bill through. So it's just sort of reached this absurd level. But what I think that the outcome will be the same, which is when you think about a sclerotic system that doesn't work for people, what do? They go around it. They find another route, and the question is, all right, what's that going to look like, and how is that going to emerge? Because it will emerge if we stay on this path. They will find other solutions.
I think you're right.
Whether that's health sharing ministries, is one example of that that hasn't really taken off like it could, but they'll find a way around it.
Not enough reason for it to take off like it could, right?
Not enough reason.
To do it yet, right?
Yeah.
I was on a call earlier today, and they were talking about not being able to get an appropriate level of cybersecurity insurance, right? And they were just saying, okay, we're just going to self-insure. Like, we're not going to pay for this unnecessary substandard policy. And so, you could look at, I think generally speaking, risk management is so under pressure, what's going to happen in Florida, right? Or so many places where you're just not going to be able to insure your properties. What are people going to do in these situations? I think, Emily, you're right. People are just going to find new cooperative models to work around it. I think that's right. I think that's
okay. So the Dems are not going to be very changed. What about the Republican side? Is there any difference?
I don't want this to sound partisan, but the fact of the matter is that Donald Trump hates healthcare. He didn't mind going after the pharmaceutical companies. They became everybody's, favorite. But this is not something he's in the weeds on. It's not even something he's interested in. He is a international tariffs, trade, defense. That's his thing.
Borders.
Okay. Oh, borders. I put that in defense. He that's his thing. So in terms of like original policies or whatever, it's probably not coming from him. But it looks like he's going to hire or engage Vivek Ramaswamy, who's a biotech executive and a venture capitalist, and Robert F. Kennedy, who has very strong feelings about the system. And whether they're able to get something done, I don't know. But what they aren't probably likely to do is stand in the way. So if everybody is saying, all right, I'm just not doing this anymore. If you're an employer, you're like, I'm not doing this, I'm going to do something different. They're not going to get in the way. That's a big difference.
Look, I'm not that well read in, but I think both of them would be much more likely to focus on the FDA than CMS. So
I tend to agree with you. I think there is some interest in a great example, star ratings. Okay.
Yeah.
The star ratings, you get a higher star rating if you prescribe statins for people with high cholesterol. So check that box. All right. Yep. Statins are pretty controversial. All right. 20% adverse effects, in some cases. But you're building it into the system. And what's happening? People are prescribing statins when it's not appropriate because they chase those star ratings. So there is some role
like
but that's pharma adjacent, but there is I think going to be some role.
Yeah, so. That's pharma adjacent. I mean, Vic, I only feel read in on this because Emily and I talked about it because we're going to do a panel with the GNVCA like the day after the election, in which there's unlikely to be sort of a clear answer on where we land. But I think the big issue as far as CMS goes is really split government. That's, like it's not about who's going to be in the White House because neither side has a strong platform to deal with just how gnarly this problem is. And the split government is also unlikely to resolve many of the issues, I would say.
Yeah. So, if Harris wins, it'll be a split government. If Trump wins, there's a chance it would be all Republican, right? I think I like government better.
It's possible. There's a number of House seats that I've been surprised have moved to toss up. So it could be that the House is shifting. A political campaign is like a wave. So if you crest too early, you're a white cap and you're done. If you crest too late, you hit the beach after the election. Okay. So your goal is to hit the beach on November the 5th. And again, not to sound partisan, I ran 3 times. I know what I'm looking at. Right now, the Trump campaign is on the right trajectory. It has the momentum. And if that is the case here 3 weeks out, you probably could have I shouldn't say that. You could have all 3 branches go to the Republicans.
Yeah. I mean, my simple assessment, which is not as good as yours, is the Senate is likely going to be Republican. And so you can't have a blue sweep because the Senate's going to be Republican. And so it's likely to be split government. And there's a small chance that the Republicans could win the White House and the House of Representatives, in which case it would be all red. I think I'd prefer, for my professional purposes, I'd prefer split government. But I don't get to decide. So.
No, you're stuck with whatever you get. But I'll
vote in Tennessee, and I'm not sure.
My assumption about the House is being challenged right now because I thought it was going to be a sure thing Democrat, but it's the thesis is getting stressed.
I listened to a Democrat kind of leaning podcast this morning who was worried about the House. But I think it's up in the air. It's unknown. Right?
Yeah, but I mean, Spanberger's district, Abigail Spanberger, great moderate member of the House, who departed. It's in toss-up, and that should not be. She should not be toss-up. She should be a D, safe D. So I don't know what's going on, but it's not turning out exactly like I thought.
Well, we have, from the date of this recording, we have 3 weeks. So
yeah. That's a lifetime.
That's so long. I just feel like let's not. I mean, Vic, the last time we were on, we were talking about how the dock workers thing was going to go long that night. So let's refrain from too many predictions, y'all, because I think the reality
it's a lifetime.
It's a roller coaster. Nobody knows where this is going to land. All right, Emily, thank you.
Sounds like healthcare is supposed to be either way, so it's good. Yeah.
I feel very comfortable with my job security in the meantime.
Right.
Yeah, same. I agree.
All right. Bye, y'all.
Thanks.
Right, thanks.